We have a rock star set of presentations today from Dr. Cheryl Case Johnson, as well as Lisa Diane White, who will be talking to us about some of the work that they have been doing in the field. Dr. Johnson is a technical officer for the World Health Organization, is an anthropologist, which is something that I share, and has been really at the front lines of offering guidelines and support for HIV self-testing around the world. And Lisa Diane White is a longtime friend and somebody who has been an inspiration to the Commission for so many years. For anybody who's been working in the field of HIV, who has done anything in the South, you probably know who Lisa Diane White is. And we're so grateful that she took some time to join us out of her busy schedule today. We have a rock star set of sessions planned for y'all the rest of the week as well. And we'll be inputting some more information for the rest of our series in the chat throughout today's session. But we're gonna go ahead and get started, and I'll pass it to Dr. Johnson to kick us off and share a little bit more about yourself if you'd like. And I know you got some slides as well. So Dr. Johnson, the floor is yours.
Let me unmute. Hi, just greetings and hello, fellow Southerners. It's a pleasure to be with you all today and talk a little bit about self-testing. It's a subject that I'm extremely passionate about. And I'm really excited to give you a global perspective about some of the happenings at WHO and opportunities for Southern states. And as a local, I got my start working in HIV and HIV self-testing back in Atlanta, and I had the pleasure to learn directly from Lisa Diane White on how to get things off the ground. So she is it's just really an honor for me to be on this panel and connected with this group. So without further ado, I'll just kick things off to walk through a little bit of what's the latest globally on HIV self-testing. So just to say what I'll try to cover today is around kind of the background and rationale about why we kind of have explored HIV self-testing and really focused on it as a topic, especially at WHO. And I'll summarize some of our key recommendations as well as our pre-qualified products. Now, I know in the US that those products may not be registered in the US, but I think it's helpful for you to know about what's happening in the rest of the world and how people are taking self-testing forward in their contexts. I'll also kind of share some updates from some recent systematic reviews we've published on HIV self-testing and some considerations for Southern states. And I just wanted to also highlight a few innovations and takeaways to be, thinking about as we start to pick up some trends around the world about how self-testing is being used even beyond HIV for hepatitis C, STIs, and emerging areas for sure. So I think at WHO, when we think about HIV self-testing, we really start back at square one around the history of where are we globally when it comes to people with HIV who know their status. And globally, when we really think back, in 2005, globally, only 10% of people with HIV were diagnosed. And there has been so many achievements and so much focus globally to really get us to the point where now we have, made a lot of progress where most people with HIV have had the opportunity to test and learn their status, but we still have a pretty substantial gap. And here, when we monitor global implementation of testing, we see we're doing, almost 500 million tests a year globally based on some 2019 data, but we still are missing some of our core critical populations that are unserved. So we're asking ourselves, what do we really need to do to stay on track and reach the remaining undiagnosed people with HIV? And when we kind of dive into the data, we look very regional. So this is the Western and Central European and North American region. And what I want to point out here is when we think about our progress towards global goals, particularly the first 95 target, which is for 95% of people with HIV to learn their status by 2030, we see that we're really stuck. We haven't really made too much headway on closing that testing gap for undiagnosed people living with HIV. And we also know in the region that the vast majority of new infections are among key populations and their partners. So when we really think about the way forward for HIV testing services in y'all's region, as well as just globally, It's really about thinking, the equity issues. Who is really being missed? How are we going to reach the remaining 12% of people with HIV in the broader region who are undiagnosed? And when we think of the strategic approaches of, who are those populations, when we dig into our data, we see this as key populations, partners of people with HIV, STI patients who just get missed. We're also increasingly seeing people with HIV who might be lost to follow-up or learned their status but never started treatment, who might need to be relinked back into care. And this past year in 2020, we have seen populations in different settings affected and missed because of COVID-19. So that's another attention area that we need to focus on. So when we think about the 2030 target and trying to reach that 95% of awareness, it's so critical for us to think about innovations such as HIV self-testing and how we can use it to reach those that are really being underserved. So just to take a step back, what is self-testing? So at WHO, we define self-testing as when a person collects their specimen, performs a rapid test, and interprets their result. And all reactive self-testing further testing. And I really want to pause here because especially in your region and in the US, there might be some really great self-sampling programs or things out there. And so while we're not covering that today, that remains a really important strategy to consider. And when we define self-testing and how the testing strategy works, when someone self-tests, we call it like an A0 or an assay 0. And so this test means that if it's reactive, that person needs further testing because no single positive result from an HIV test can be sufficient to give a lifeline diagnosis. We have testing algorithms that provide the full diagnosis, and we really want to refer people to the services they need to get that. And it's somebody who has a non-reactive or negative self-test result. We would treat that as negative, but it's important when you're distributing a self-test or talking to people about self-testing that they're aware of how they should access, either retesting or prevention services. And really happy to speak to prevention services as, such a core to all of the work that we do. So this is just to give you a little bit of a summary of, well, what does our WHO guidance say when it comes to self-testing? We updated these guidelines just at the end of 2019. I'll walk through in the slides to come about the evidence, but really just to say that the quality of evidence that we built this recommendation on draws from 32 randomized controlled trials and over 100, close to 150 values and preference and qualitative studies globally around the world. So this is something that we categorize as a strong recommendation. And we did add some new remarks that I would really like to highlight because it's become increasingly clear that communities are essential to the success of these interventions and very important to be included into the design and implementation. Now, as I mentioned, there are a number of products that are WHO pre-qualified. Now, the products that are on our list are these 4. So there's 1 oral fluid product and 3 other blood-based products. Now, globally, those products that are WHO pre-qualified for the rest of the world through procurers such as Global Fund, and even in PAHO through the Strategic Fund, can be procured for between $2 and $3. We also do have some procurement, an updated product that just came through with a kind of a special approval that's coming in around $1.50. Now, I know that those price points are much lower than what you're used to in the US, and I flag them because it does raise an important conversation about what the affordability of self-testing should look like moving forward in the US and what other innovations and options could help address that gap. Now, when we talk about self-testing, often people focus in on the test kit, but it's the intervention. It's the things that come along with it. It's more than just the self-test kit. We have so many different implementation models. It can be, from a community organization. It could be based at a facility. It can be online through social media or mail delivery. It can be delivered through partners or peers, vending machines or pharmacies, faith-based organizations, even at the workplace. So there's lots of models to choose from, and I encourage you to check out some of these resources. And also there's a lot of support tools that come along with these. So you might have in-person demonstrations or videos, hotlines, SMS or short text messaging or Twitter chats, WhatsApp, other messaging services, as well as other pamphlets and local information resources. So there's a wide range of tools that are out there for self-testing. And since we made our recommendation, the first time we released our guidelines was in 2016, we've seen a significant growth. So now if we think about the countries with testing or self-testing policies, we have about 47 that have a policy, and we have, of those in addition, I misspoke. So we have 88 countries that have a policy and are implementing self-testing. And so we make that differentiation because we want to see more countries rolling out and scaling up self-testing. So we still see a lot of gaps, but it's really important to mark that progress that since 2015, we've really moved beyond a small number of countries with policies to really starting to see more and more countries taking this intervention up. This just gives you that global coverage of, which countries around the world are taking self-testing forward, and massive progress has really been made. But as I say that, when we think about globally, when we break down the regions, there's a lot of countries and regions that haven't taken self-testing forward or might have a policy in place but haven't really started implementing. So just to highlight the region where the US is located in North America, while we might have a significant number of policies overall, mostly coming from Europe, we know the implementation in the US is quite small. And that is an area of a need to really expand, particularly when we think about what it would take to really achieve the 95, 95, 95 targets globally. And just to give you a sense, the market's really growing. So when we look across low and middle income countries, we do see that the need and the total estimated need is now around 177 million kits, growing to around 192 million kits. So this market for self-testing really is quite global and expanding rapidly. So I want to transition now into a little bit of the background evidence. And there's kind of 3 systematic reviews that are quite recent from WHO that I wanted to pull out that might stimulate some discussion or ideas for Southern states. So one of the systematic reviews published in BMC Medicine pulls together 11 randomized controlled trials. It focuses specifically on key populations, and 4 of those studies are from the US specifically. Then we have a broader systematic review that's in press, Jamil 2021. And this pulls together from 32 randomized controlled trials, and a separate publication, a sister review, focuses on the values and preferences piece. And then we have one that actually just came out in Clinical Infectious Diseases that's looking at a network meta-analysis, and it really compares the distribution strategies. So I pulled that out together. So I'll kind of touch on the findings from these reviews and look forward to questions or queries about what we're finding. So overall, when it comes to self-testing, we do see that it increases the uptake of testing when we compare it to standard services among key populations. The results are really consistent, and I highlight to you here that online or mail distribution is really effective when it comes to men who have sex with men or transgender people. And all the studies, except for I think 2 here, are coming from the US in that red highlighted box. And from our network meta-analysis, when we compare across different testing approaches for distributing self-tests, it's the online mail distribution that is the most effective when we compare to the standard facility-based approaches. And so here again, while we don't have that many in our network, so we have 3 studies, they're primarily men who have sex with men in the samples, it does give us encouragement that the online or mail distribution could really increase uptake in North America and the US. We also see across our reviews that self-testing can more than double testing frequency. And we know this is really important to our treatment and our prevention goals to ensure those who are positive are placed on treatment as early as possible, and that we also are getting prevention services scaled up to really ensure reduction in transmission. So this is just, again, showing the benefits of targeting something like self-testing towards those at high ongoing risk. We see that because of that increased uptake and increased frequency, that self-testing compared to standard testing also more than doubled positivity. So when really effectively targeted, we do see a benefit of self-testing as a way to reach those who might not be coming into services and who are more likely to be positive. And we do see from our subgroup analysis that online and mail self-testing distribution was also more effective than standard testing in terms of positivity. Now, I've got a little bit of a complicated message on linkage, so I would ask you just to bear with me. So linkage to care, I think, is one of the most challenging and big questions we've always asked about self-testing. So across our 3 reviews, we found some different trends that I think are worth unpacking with you. So on the kind of to the left, where you see the meta-analysis on linkage among the overall general population that compares self-testing to standard testing, we see no difference in linkage following self-testing compared to standard testing. And this compilation of studies, it's looking particularly at the general population, mixed populations, and it's looking across various service delivery approaches, and it brings together some evidence across Africa, Asia, and the Americas. And more people are diagnosed and linked to care overall in terms of absolute numbers, but we don't see a significant difference or benefit when we look across either for self-testing or standard testing. However, when we looked specifically among key populations in our most recent review, we do see that there's a slight decrease in linkage to care following self-testing among key populations. And this, while we saw no difference in the red highlighted box when we looked specifically at men who have sex with men or transgender people, we did have 2 studies that seem to be really driving the effect for sex workers, and that there may be a need for more support. And I would highlight to you that both of those sex worker studies did come from the African context, and they used more of a peer distribution model among sex workers. So I think it's important to talk about some of the differences, but probably for your context, it's more encouraging that we're not seeing a reduction in linkage among men who have sex with men and transgender people, which is using some of those models in these studies being potentially useful to think about in southern states. So at this point, we're not really seeing a difference, but we saw the same kind of trend, which was encouraging to us in the network meta-analysis, that there was also no significant difference when we looked across comparing the different service delivery strategies as well. So again, highlighting that there didn't appear to be a difference between standard testing or self-testing. However, I think there's a different conversation worth having with self-testing or just general testing, which is we could always be doing better on linkage. So what are we doing, or what interventions work to enhance linkage up and support? So we did look at studies that had support tools or strategies to increase linkage as part of their design. And we found 3 randomized controlled trials that had some additional benefit. So in Africa, we did see the home ART initiation showing a benefit to linkage, a linkage escort, again, that study coming from Zambia, and then a provider's incentive with that study coming from Zimbabwe. But I think these are,
my apologies. Would you mind if we just slow down a little for our interpreter?
I'm so sorry.
We want to make sure that our Spanish speakers are able to get all of these gems.
Absolutely. Thank you for the reminder. Apologies, Susan and team and everyone. So I think I'll wrap up this point just to say, when it comes to linkage, it seems that it's possible that there's probably no difference between standard testing and self-testing and linkage to care. But when it comes to key populations, we know that linkage could be lower, and we should be exploring some linkage enhancing support ideas and strategies that could really optimize and really ensure that we're not leaving folks behind. So something to think about for any self-testing program, to design an approach with the local community that could really work to support linkage. Now, there's additional results from these reviews that I wanted to touch on. One, that across all the studies we've seen and our reviews, there's been no suicides, and other social harms were quite rare. We saw no difference in uptake or frequency of STI testing when measured across studies. We saw no difference in condom use. Cost and cost effectiveness, it did vary widely. And I think that's true to any global review, that you're going to see big differences. But we were really encouraged that we saw that costs can be comparable to other outreach models that are used in countries, especially when they're focused on those with the greatest burden of undiagnosed HIV. And then finally, we did find a lot of evidence suggesting that communities find self-testing to be empowering, a very useful tool to access health services that they might not otherwise, but also to think about ways that they can reach out to others, and some really encouraging information coming out from communities on the power they see of self-testing. Now, I didn't go into detail, but I did want to touch on the qualitative values and preferences work. And this was just a very quick summary to say there's a lot of different viewpoints on what makes a good self-test. But in general, everyone wants a clear and simple product, one that's discreet and highly accurate. We see some folks prefer oral fluid self-tests, but there are quite a number of people who would value a blood-based self-test. So offering both options could be really strategic for countries long-term to ensure you reach the most people and really reach those with undiagnosed HIV. And providers, of course, have strong views about the quality of those tests. So again, that should be factored into some of the messaging when rolling out self-testing programs that providers are on board. So I've shown you the WHO recommendations and a little bit of the background of the evidence, as well as how we arrived at that guidance. And then the question really begins with, well, what do we do with this? How do we implement self-testing in an effective way? And it's going to change based on your epidemic, your testing gap. There's so many self-testing approaches out there. And then there's special considerations, talking with the local community and thinking about that context around which support tools make sense, how to do linkage with your system. So one strategy and decision tree we have in the guidelines really works to help countries identify which approaches might be great for them. And this is one just visual example on a slide, but there's a whole systematic process that one can then go through to select the most optimal model, considering your targets and the type of program you run. I did want to quickly touch on as well that we've seen a lot of countries taking up self-testing in the context of COVID. So early on in the response to COVID, WHO released some essential services guidance, and self-testing was highlighted as an acceptable alternative to maintaining services while adhering to physical distancing guidance. We've seen a lot of countries utilize self-testing as a way to continue their program, to monitor PrEP, which we're going to be reviewing evidence on that this year, to decongest health facilities. So there's really a lot of options to explore with COVID-19, and we're in the process of reviewing some of that evidence. So if you or your partners have been working on anything in that context, we at WHO would love to review that and really learn from your experience. But do think about this for the years to come as a new strategy to really help us globally expand self-testing and address future COVID surges and work towards better planning and prevention, when it comes to maintaining essential HIV testing services. So really quickly, I did want to share just some additional innovations on the horizons when it comes to self-testing. So one, HCV self-testing is coming into implementation near you very soon. I know at the CROI conference coming up, there will be some updates on this shared. WHO is actively working on guidelines and supporting implementation pilots. And we're also in close discussion with several partners about trying some STI technologies for self-testing. So I think if you're thinking about self-testing for HIV, you might also want to start talking about HCV or STIs. As I mentioned, the expanded use of self-testing for PrEP monitoring, this is not currently recommended, but it's something we'll be looking into later this year based on some upcoming findings and research that should be published towards the mid-2021. And again, as I noted, affordability is still a priority and something we're really working on, and I think need to work on when it comes to access to lower cost products to help us achieve scale. And as I noted, there's a big demand for programs to start to have models that can operate well during COVID restrictions that might make it feasible to maintain services in a really effective way. And so there's active operational research going on, and we'll be looking into that over this next year. And we're actively working on some guidance around HIV testing and catch-up planning that includes self-testing in response to COVID. So I've given just a few takeaways here that yes, self-testing is a critical strategy for reaching the first 95 target in southern states in the US. Really something to think about. Online and mail distribution are great options, as well as partner and peer-driven strategies. Linkage is also something that can be really improved or optimized, so something to really focus on planning. Lots of growing opportunities in the market, and perhaps greater efforts can be engaged in to really achieve greater scale, introduce some diversity of products, including in the US. And as I noted, a lot of new innovations in the pipeline that could really benefit from the lessons learned from early self-testing programs in the US or southern states. So something to think about how you might integrate these other products into your active work. All of this information and more is available on our app, the WHO HTS Info app. And Spanish is coming soon. I know my colleague Emmanuel Fajardo is online, and we do have our guidance in Spanish. So if you do need it, let us know so we can get that to you. But just really thank you to everyone who's contributed to the reviews, the guidance at WHO. We have a forecasting team and manufacturers and many folks who share data that makes it possible for us to pull this together. And just really want to thank you all for the invitation to speak today. It's been such a pleasure to be with you. So thanks so much. And there's an annex as well for reference if ever useful.
Wonderful. Thank you, Dr. Johnson. I really appreciate that comprehensive overview of all of the work that you've been doing for the last several years on this topic. I wanted to, before we bring up the wonderful Lisa Diane White to share with us, to highlight something that you mentioned about midway through your presentation, which is that you said that instances of social harm were, in the context of self-testing, were rare. And I think that's a key point because while traditional clinical sites are so crucial and invaluable in the South, we know that many of our community members often face barriers to accessing many of those traditional clinical sites, right? And so having that kind of research that can really help us unpack that is key for this work. And I know that Lisa has been one of the champions highlighting some of those barriers and confronting them and undoing them. And I definitely want to hear more. Lisa, if you want to come up and share. And while you do that, I'm gonna download your app, Dr. Johnson. I didn't know that y'all had an app around HIV self-testing, so that's something I like.
Hey, we're trying to modernize, you know, keep up with the times, put ourselves out there on the app so you can find us.
Yes, thank you. But with that, I'll go ahead and pass it to Lisa Diane White, Deputy Director of SisterLove. And I'll put a link to SisterLove in the chat so folks can learn more about SisterLove as well.
And before I start, I did have a question for Dr. Cheryl. When I was looking at your summary, that I saw that some of the linkage for female sex workers, that linkage was not as robust. And I don't know if that linkage was robust originally. So that was kind of something that stood out for me. And I also wanted to know, is it just all female sex workers? Were there any other sex workers that were looked at, including male and transgender sex workers?
Great question. So one, I'd say our evidence around the sex worker linkage is limited to those two studies. And because there were fewer positive cases, you know, the robustness is, it's low quality evidence. I think what it tells us in this context, it was just female sex workers, one study in Zambia, one study in Uganda, and they used kind of a peer educator or social network model. And I think if you were to engage in self-testing, like with a social network model with female sex workers, we've gotten some feedback from sex worker networks and from other researchers kind of in the field that sometimes peer educators may not be the best placed for distributing self-test kits. So I think that's where the local community really has to be engaged when you think about what's the best option. But I do think we probably need to dig a little deeper when it comes to sex workers and their self-testing preferences and how linkage could be better supported, because it did come up with those studies and it definitely wasn't signaling in the others. So there may be something really to, hey, we need to spend a little bit more time talking with sex workers about how self-testing programs could be really optimized for them. But it is quite limited information in terms of, what we can really derive from it.
Thank you. It is my pleasure to be here to talk about SisterLove's home testing program. And we were like many agencies who began to scramble to figure out how to do services when we first shut down in March. And so we had a lack of information about, COVID transmission. We had a lot of anxiety. And we also had a number of staff that had multiple, comorbidities, including HIV, being HIV positive, having lupus and other autoimmune, illnesses, suffering from diabetes, hypertension, pretty much what our population looks like. And also, if you start looking at undiagnosed, comorbidities, we had plenty of people who did not know that they had, diabetes, who did not know that their blood pressure was high. And so we started noticing all of these things that were making our numbers rise when it came down to our COVID deaths. And so we had to pay attention to the fact that these are the same population that we're dealing with that don't know their HIV status. And so one of the, I was quite surprised to see the cost of the testing there, because our self-tests have been with the Aura, sure, and those tests range from over $25 a pop. And then when you start adding in the places where we begin to mail out those tests, that was an additional $8 and 50 cents, and that was hopefully us trying to get that priority mail. And so if you've been looking for your packages that have come in priority mail, I'm still getting Christmas cards that were mailed out in December. So that really kind of touches on some of the difficulties around us using the mail system, trying to get out our kits when we are talking about trying to get them out in a timely manner, within a 24-hour period of when you call us saying that you are looking for an HIV test. But I'll go back to the beginning. We used to have a very robust response for testing, and particularly among women, because most of the women that we are seeing are typically calling us because they want to be tested for an STI. It's very easy to know when you have an STI, maybe for many women, because there's some itching or some burning or something that is happening that alerts them to something has happened. And since our STI program is not funded, we also use this as an opportunity to invite people to enroll and get an HIV test as well. So we were seeing upwards of 80 requests a week or more for STI and HIV testing. And so when COVID hit, those numbers were still coming in, but we weren't open. So we began to make referrals. And so we remembered that we had done some outreach for the Essence Festival, and we had several HIV home testing kits. And so we began to think that maybe we could send those test kits out for people. And so we began to send them out. And we also began to get a number of proposals asking us if we wanted to apply for emergency funding. And we were able to successfully, get several grants to help us apply for the emergency funding. And the majority of the expense went toward purchasing the tests and also mailing them out. And so we had to use, additional funding that we've already had to pay for the workers to do that. But this was, something that we scrambled to do. We also had to develop, policy and procedures about how that would go. And these are just, we were so excited with our innovative thinking, and we began to, work with the maker of the Horseshoe to talk about, ways that they were already, saying, we wanted to know how had the program been in home testing. And of course, those numbers went up. The health department was scrambling to get kits. We were testing with Walgreens, and we had a robust, program, for our various HIV testing awareness days. And so we became kind of like the poster people around look what we're doing. And we've got all these tests. So we didn't even have to buy them again until we received additional funding. But we were just looking for creative ways to get testing still done in the midst of all of our knowledge and lack of knowledge about COVID. Also keep the staff safe because, we shut down everything. We had to, improve our ability to do, virtual work, i.e., we had to get people computers, and we had to get people, access to understanding how to do those computers. And we had to understand who's open for linkage to care and who is open for referrals when we, didn't have anybody testing, so by the time, Atlanta shut down, I'm pretty sure if anyone is familiar with the news and the political, environment in Atlanta, we fight everything. We don't want to be told what to do. We want to do exactly what we want to do. And we are, a strong advocacy agency in terms of making sure that we have access. And so, so we celebrated our successes and we updated our policies. We looked at best practices that had been occurring. And we were looking at about a 50%, success rate, from what we had seen coming out of some of the data that we saw from out of New York in terms of people who got sent the kit and then they were able to connect to in terms of getting their results. And so we came in all gung-ho, we're like, oh, we got 100%, we set up, mailing out our test kits and sending them out to people. And we weren't having as much problem with the mail system at the time. We may have a day lag, but we weren't having, a week-long lag like we had started experiencing around the holidays. But, we got our kits out and then we used an app or something, how you have to keep up with what the word is that you're using, but it was called Simple Practice. And what we were able to do was to set up a confidential, testing with the person. We walked them, we asked them not to open the kits until we mailed them to them, and when they got them, we sent it out in a very discreet packaging. We sent out, safer sex kits. We sent out condoms. We sent out lube. We also sent out instructions on safer sex, with COVID-19 based on the new information that we had been getting. So everything is real time. We're trying to, adapt ourselves. And we begin to walk people through the testing and to get those testing results. But what we were finding is that women needed to be tested for the STIs. They didn't just want to be tested for HIV. And so we're sending them these elaborate kits to test, but we are not sending them what they're needing, which is HIV test, which is STI testing. So we begin to look at, when we wrote for some of these grants, we began to look at what is some of the protective equipment that we can buy for staff to put on, such as masks and shields and the little yellow gowns. And then we were like, well, even if you come in, we can use that simple practice, talk to you on the phone, but you're in our office. We can walk you through the test kit and we can, help you determine what your test result is as well, more accurately.
Ms. Lisa, sorry. While you're talking about the protective equipment, could you slow down a little bit for our interpreter? I apologize.
I thought I was doing my very slowest voice.
Thank you. I understand.
I'm so sorry.
We're doing it together, so I appreciate it.
Okay. So we ordered things like masks, shields, those little yellow gowns that you see people wearing, and we struggled with what is the best mask, and people are like, I got COVID and I wore my mask. And so it depends on what type of mask you wear, what is the effectiveness of the mask. We had to learn all those things as we began to order things, and we learned by trial and error. And so we mailed out kits, but we weren't getting the response like we had been getting weekly, the 80 to 100, requests for testing. They were dropping weekly, and sometimes we were only getting 10, and things just shifted because, people, we didn't know if people weren't coming out or whether the people that we had made referrals, were they going to the other agencies where we made referrals? So then we had to do marketing as well to let people know that we were still in service and what we were doing around the test kits. But we also learned about, the social determinants of health. We talk about poverty. We talk about, access. And what we learned is that the digital divide became another social determinant of health. And so we were sending these kits, and some people, began to open their kits, do their own test, and get their results, and did not care if we needed those results, but what we were doing was collecting data up front. We had demographic data. We filled out all of the paperwork, we understood what the risk factors were. So we collected all this data up front before a test was even sent. But we also knew that there was urgency based on the data that we collected, because we also wanted them to get these tests within the 72-hour period if they had been exposed to HIV, so that they could get access to PEP, post-exposure prophylaxis, as well. So these are, a number of things, as I'm going through, my early, memory about what was happening. These are multiple things that were happening. But again, we were still excited about the fact that we got the funding. We were able to pay for those expensive kits. And we also had the funding to mail out those kits. And we got that funding for 2020. Now that funding has not been extended into 2021, but we are also, still looking for additional funding to support that type of activity. And so some of the things that I learned is that people, again, had difficulty, because we wanted to refer people who were HIV positive, who tested positive. We wanted to refer them to, support. And we found out that, many people at that point did not follow up. They stopped answering their phones, and, and we had difficulty, with our linkage to care. We also found that we had quite a bit of user error. So when you have user error, we had home kits where they were testing, reactive. So we had at least 5 of those. That's a very high percentage for a reactive test that we hadn't been seeing. And we thought something was wrong with the manufacturer's, offering in terms of how we stored it, or whether or not, we were giving people instructions on how to follow it correctly. And what happens is, if you tell us that if you don't tell us that you ate or what you had before you administered the test, then that does impact the possibility. But the good thing is that by that time, we felt safe enough to bring people into the office and to test them with the INSTI, where we would do a finger stick. And so we did find that those were more accurate, and we felt we had the capability of taking that blood sample. And we found that our clients did not prefer to do the blood sample for themselves, that they preferred for us to do it. Now, some of the strategies that we utilized to get out the home testing kits when we needed to do more marketing is that we began to partner with sites who were doing COVID-19 testing. So we would, take all the data that we had normally been collecting, and we would ask clients to meet us at testing sites around the city where we were doing COVID-19 testing. And we were able to get several test kits, distributed, and collect the data and to follow up. So that was a successful strategy that worked for us. And we also, we worked in partnership with churches. So the churches were testing and learning how to test, and then the universities were, getting, getting themselves in partnership. And we had a number of faith-based staff who linked us to their churching. So that gave us a successful strategy. And so I think those are the things that I wanted to highlight that went well, and some of the things that we struggled with. And I would say that cost is one of those things. I was quite excited to see those numbers. I thought, well, who do you know to get those types of costs, internationally? And I'm not sure if that, what impacts the policy for us in terms of how much these test kits cost for us. But we are, constantly looking for new and innovative ways. And we consider ourselves, someone that is constantly on the forefront. We had to look at our testing rates before we did home testing as far as women. And we are reaching the at-risk population because the women that we are serving, they test positive for, syphilis, gonorrhea, chlamydia, or trichomonas. So we know that they have had instances of condomless sex. And so we're able to say that we are reaching a at-risk population, but they're not testing positive for HIV. But they are, so what we do is we keep SisterLove in terms of keeping women on the forefront of what is happening and what the risk factors are for women. And we're trying to make sure that we're looking at the multiple issues that impact women, and to make sure that, whether funding follows or not, how are we developing innovative ways to reach women, to find out what their status is, and to keep them on the radar of our funders who may not find them to be the priority population that we do. So I will stop. I don't know if it's too late to slow down, but anything that you missed, I can repeat happily.
Thank you, Lisa, and for giving us, that overview of SisterLove's really path-breaking work on self-testing in Georgia and for a lot of other CBOs in the South. I know that a lot of folks have turned to SisterLove for inspiration, and I have to say that it has the best website design of many of the organizations that I've encountered. So y'all are definitely doing great work there. And I want to encourage our participants to send any questions they have for either of our speakers in the chat or through the Q&A function. And while they're doing that, wanted to just ask y'all to see if y'all had any more questions for each other, or if you wanted to comment on some of the non-traditional or traditional partners that y'all worked with in this work. I know Lisa was naming churches and universities, and that you also maybe named having conversations with Horseshoe. I think that's what I heard. So I think that's an interesting thing. And Dr. Johnson was naming also peers, right? The importance of activating those folks who are in the social network, right, of our priority population, right? Who might not themselves be a member of the priority population, but who might be engaged in sex with them, right? So if y'all could talk about some of those other partners.
We did utilize, I guess a social networking strategy that if you called in to get tested, we knew that you had a partner. And so we encouraged them to, share that information with their partner. And we also encouraged them not to try, to use, the kit twice, because, we like to, share. And so we wanted people to understand the importance of everyone, using the material once. And I think that when it came down to partnering, we partnered with Horseshoe so they could talk about some of their best practice, how to get a discount on some of our ordering. So we ordered quite a bit, but the discount never even dropped out of the 20, Dr. Cheryl. So I'm just really, again, excited about those numbers that you all are seeing in the Africas.
Yeah. No, I mean, I was just so, one thing I was going to say is, we similarly, I was so glad you said faith-based organizations, because we've started to see some really innovative models come out from churches. And there was one I know in Kenya where they were, really working with folks that, in the church, there's people that are doing more of the outreach and, listening to people around the counseling messages. And those folks, they began equipping with the self-test kits as they kind of did their outreach ministry work. And that became this really one important community dialogue where you had somebody who was, talking about it, giving a demonstration of how to self-test. So there was an awareness raising piece that the church was kind of taking on, as well as then, actually distributing and helping with that. And so I would just echo that we've had some really tremendous success with faith partners with the self-test kits, a lot of enthusiasm as well. And then in terms of some of the user error, I was, interested, it's always interesting for us to hear, what steps mess people up or what kind of are the hiccups. And early days for us, I think we did see sometimes folks that are so new to self-testing, even opening the package or where to start is like, this is overwhelming. So we started doing these WhatsApp videos and sending them via text message. So that was definitely something that we did see some success with to try to at least address some of the early mistakes. But the sample collection, I think some people, it's just, you'll laugh at this, but in one of the studies we did, we looked at men and women, and the women read the instructions and the men, they just go diagonal and they didn't read it at all. And my research partner said, did we need funding to know that? I digress, but the reality I think was, okay, like you're going to struggle to get folks to really read stuff because they just want to do it. So little videos or in-person demonstration or things that people can remember seem to really be really beneficial just to get the first time they self-test. There's so many questions and it's easy to do things out of order and, make a mistake. And so I think that maybe is just one area that I'm like, as more people get comfortable with it and know about it, it just gets easier, I think. But I don't know.
And that worked for our follow-up response when we did, our 60 to 90 day follow-up, people felt more comfortable. But if you struggled with interpretation or the pictures may not be helpful, we thought that we really had an innovative piece where we walked you through it. Don't open your package. We'll show you how to open it, how to set it up. We were on camera with you. So that worked really well. We supported people around getting the, to wait for the results. And so we could see them, via the camera. So if you had all of those virtual equipment and things, then it went well. So what we found is that people who did not have access to those things or who did not have the data or, a number of things that don't allow them to have a seamless encounter, based on, the technology or the cell tower or anything, and then when the mail became a problem, we were really like, are you serious?
That's so tough.
These are realities, but at the same time, like I said, we then moved to the parking lot when it was warm, and we were, self-testing, through the window, watching the swab just like they were doing. So we watched how they were doing COVID testing, and so we practiced the same things. And all of our staff, I have to say that, they're quite, resilient and brilliant, and everyone had been exposed to COVID-19 and then got COVID. And we're not quite sure whether they got it, via testing, via their own home practices. A lot of people just simply don't know. And so that same stigma that how did you get HIV? It applies to how did you get COVID? Who were you with? What did you do? Is it your fault? And, even I heard on one thing, Black people get COVID more because we don't practice cleanliness, hygiene that came from a doctor over. So, we're still dealing with those types of stigmas. And so we just recognize that stigma is prevalent regardless when you're talking about HIV, and we are mindful of that always.
And the both of y'all are definitely champions for stigma-free prevention and care. And so in that vein, I know that we have some folks that are asking a few questions. We're short on time, so I'll go ahead and just read them out loud all at once. And if possible, if y'all feel comfortable, you can put your emails so people can follow up with you directly as well in the chat. But we did get some questions around just like the user side of things that y'all were talking about. And we did have one request in the chat to see if those WhatsApp videos were shareable. If that's something that folks could request, maybe they can send you an email directly to request those videos. And we also had some conversation around the false positives, right? And y'all were addressing that with the videos and maybe some other interventions you were doing, but if either of y'all wants to comment more on that. And we did get another question from Brian Collins, who is actually going to be on our roundtable on Thursday, great champion for HIV self-testing in Virginia, asking if a lot of the literature comes from self-reported information, or if it includes national surveillance data, if that's where some of these studies were coming from. But if y'all wanted to comment on any of those, whether the false positives, or incentives y'all used to help educate people on how to use the tests.
We didn't offer any incentives other than the testing is free, that we will mail the kit to you for free, and that we will walk you through for free. And we got some of our data about home testing from the company, for sure, and they have some studies that came from out of New York about a program that they use. Then we use some data from Long Beach, California, about pull-up testing on the parking lot, and we took those policies and adapted those and utilized those to test through the window. So, and as far as the false positive, if we weren't able to walk you through it, then we had to do a blood test if it was reactive, because that's the most accurate way to do the to do the follow-up. And all of those second tests came out non-reactive.
And maybe just to add on to the data thing, I think it's important that we as folks working in HIV testing, we recognize that with the benefits of self-testing, the increased privacy, the discretion, the access, the data is going to be different. So there's going to be things we can't really do one-to-one. So an approach we've really started to move towards at WHO, has been to triangulate some of the different data. So using some manufacturer data, some geospatial data where we can, like the general testing data that we do see in our clinics and in the programs where we would see the confirmatory testing pop up. As well as, special surveys. We've done some, social media follow-up with a sample of self-tests. Like that's also been a very effective data collection method. It's not up online yet, but at the end of 2020, we finalized a M&E module for self-testing. So I'd be really happy to circulate that through the group. And it really focuses on, because the data's, it's not going to be one-to-one, or sometimes, you're going to have bias in that data. So how can you bring it together in a way that gives you a better sense of what's going on and where the problems are? And I think that there's a strong role for, quality improvement tools for self-testing too. So it's just to say some of our data should be kind of in that feedback loop of, well, how can I make this service better? How can I, make it more accessible? Because I will say we have to be a little cautious that there are some folks when it comes to self-testing, if we try to follow up too hard, it's going to have the reverse effect, and then I don't want to get tested. So I think we're always trying to find the right balance of, there's lots of options. If you want to self-test, we can, find a data system to get us what we need to know if the program's working, but it is going to be different than our standard testing data. Yeah, maybe I just was saying we've got a number of protocols too for folks looking at operational research. So I've shared that link if you're interested in just some very basic operational research, some great places to start online.